Namaste, friends. Welcome to this curtain raiser press conference ahead of the 17th National Conference of AIDS Society of India, or ASICON 2026. This 2 days conference will be held in Mumbai, India, on 6th and 7th March, on the theme of Adding Life to Years with Science and Solidarity. Two important workshops will also be held, one on 5th March and the other on 8th March, as part of the scientific program of ASICON 2026. Addressing this press conference today will be Dr. Ishwar Gilada, Emeritus President of AIDS Society of India and Governing Council member of International AIDS Society, and also Chair of IS, that is International AIDS Society Asia Pacific. We also have Dr. Glory Alexander, President of AIDS Society of India and Founder Director of Asha Foundation, Bengaluru. Also, Dr. N. Kumaraswamy, Vice President of AIDS Society of India and Chief and Director, WHS Infectious Diseases Medical Center. Dr. Naval Chandra, Secretary General of AIDS Society of India and President and Unit Head, General Medicine Department, Nizam Institute of Medical Sciences, Hyderabad, and Trupti Gilada, Joint Secretary, AIDS Society of India, an infectious diseases expert at Unison Medicare and Research Center and Masina Hospital, Mumbai. I now hand over the mic to Dr. Gilada with a question that can you please give us an overview of India's goal to end AIDS by 2026 now and achieving 95, 95, 99 goals under Mission AIDS Suraksha. Over to you, sir.
Thank you very much. Whenever such goals are made, either by WHO, UNAIDS, or international agencies, they are with the idea to galvanize the machinery towards a particular theme and goal and by a given time so that the machinery works towards that. It doesn't mean that if we did not achieve that goal, we have been poor in working. The goal was initially for 2020, it was extended to 2025. So for 2020, it was 90. Now it is 95, 95, 95. From 25, they extended to 26. There are smaller countries in the world, and they were having a much more challenging times than India. And they have achieved 95, 95, 95, almost up to 98 or 99%. And I don't have to name those countries, but most of those countries are from Africa and only Cambodia from India, from Asia Pacific. India is currently at 80, 92, and 98. 98%, let me explain to those people who may not know details. The goal is 95% of those people who are infected, they should know their HIV status. So currently in India, 80% of the people know their status. Remaining 20% people do not know their status. And this is a challenging task for us because the last mile connectivity, which I'll cover in my next part of intervention, is very difficult. There are people hard to reach. There are people which are called MSM or male sex with male. There are bisexual who do not acknowledge their MSM activity. There are people who are doing hidden prostitution, which is not street brothel kind of prostitution. So, and jails and remand homes, injection drug users. So they are always scared of the authorities, scared of the kind of implementation machineries that they might be caught. And therefore, it is the job of NGOs, it is the job of the private doctors to reach those remaining 20%. And it is the job of the government to get a kind of a good public-private partnership to have a last mile connectivity. The next 95 is 95% of those people who have HIV, they should be put on the antiretroviral therapy. And that is a lifesaver therapy. That is a therapy which makes people live entire full life. Not one single day is reducing your lifespan if you are on a regular ART. And they become undetectable to untransmittable to others, so that once they are controlled with HIV treatment, they do not transmit to somebody else, including their spouse or the child which is going to be born after that. Here we are around 92%, a good achievement. The last 95 is 95% of those people who are on ART, they should have controlled viral load. Their viral load should be 0, which is called target not detected, or below detectable level. That can be either 34 copies per ml of blood or 40 copies per ml of blood, depending on what test you are using. And here, India has done a remarkable job. 98% of the goal is achieved rather than 95. And we are late starter in that. We started viral load testing only after 2018. And that time it was public-private partnership with private laboratories. Now the government of India, through their lab setup, they have seen that all the viral loads are done in the government setup, in the ART center setup, in the labs which are governed by NACO. So here is an excellent. But what happens is, if you are weak in the first 80, then you are weak everywhere, because when you are calculating first 80 is 80%, so 92% of 80% and 95 or 98% of that 80%, that becomes a smaller number. And therefore, our major and daunting task is to have that kind of 80% goes to 95. And thereby we need a major push. And why it is not happening, there are multiple reasons. But currently, the major focus from the government machinery, National AIDS Control Program, is on treatment. So when the focus goes to next strategy or treatment or viral load testing or suppression, then the previous goal should have been not been neglected. So we have a very poor prevention program now. Targeted intervention, which are usually done by NGOs, they are not getting the funds, their focus is not there. So we need to re-engage NGOs, we need to re-engage those people which are working on prevention, and therefore all these strategies to be met to reach the goal from 80 to 95. Thank you. Sure.
Thank you, Dr. Gilada. Dr. Gloria Alexander, we would like you to share the progress and way forward towards eliminating vertical transmission of HIV and preventing HPV-related cancers in India among people living with HIV.
Good afternoon, everybody. Thank you, Shobha. With regard to prevention of mother-to-child transmission of HIV in India, we have made considerable progress, but we have not completely eliminated mother-to-child transmission of HIV. Before treatment was available, the risk of transmission from a pregnant HIV-positive mother to her newborn child was in the range of 15 to 45%, closer to 45% if it is a breastfeeding population, which it is in India. But with the advent of ART and all the new regulations and rules and guidelines that we follow with regard to prevention of mother-to-child transmission, this risk has reduced considerably. The problem is that we have about 27 to 29 million pregnancies per year. To access all these women who are pregnant and to do the HIV testing on them is a huge task. In spite of that, in the latest annual report of the National AIDS Control Organization, we have achieved 83% of all women have been tested for HIV in as far as HIV is concerned in pregnancy, and about 78% have been tested in all pregnant women for syphilis. And we have been able to identify around 16,000 of the 19,000 people who are expected to be living with HIV and who are pregnant. Around 16,211 women were identified. Of this, a little less than 50% were newly identified HIV positive women, and the remaining were actually women who were already identified on treatment and who came probably with second pregnancies. In the number of babies that have been tested for HIV, newborn babies, what we refer to as infant diagnosis, early infant diagnosis, the risk of transmission has been identified as 0.71%, which is actually less than 1%. We are doing pretty well there in all the women that we've been able to identify, treat, and test their babies, but we really need to reach zero. So that is the whole aim when we talk about elimination of mother-to-child transmission of HIV as well as syphilis, because this is a combined effort that is being done, a single window approach, where we handle both these infections using a single window. So that's where we are at the present, and I'm sure with a little more time, we'll be able to achieve the WHO definition of elimination of mother-to-child transmission of both HIV and syphilis. Coming to cancer cervix, as you all know, cancer cervix is the second most commonest cancer in women in India. And cancer cervix in India accounts for about 25% of the world's cancer cervix. So that is a significant amount. Every year, about 120,000 new cases of women women are diagnosed with the cancer cervix. And About 80,000 women die each year from cancer cervix. So it's very important that this cancer cervix should be eliminated in the country. Fortunately, we have a vaccine called the human papilloma vaccine, which the human papilloma virus is responsible in India for almost 84% of all cancer cervix. So by giving this vaccine to children, we can eliminate their chances of acquiring cancer cervix later on in life once they become young adults or older adults. So, coming to women living with HIV, women living with HIV have a six-fold higher chance of getting CA cervix compared to the normal women population. Whereas in women who do not have HIV, we need to give 2 or 3 doses. In women living with HIV, children living with HIV, we have to give 3 doses of the HPV vaccine. And we need to give it at day 0, day 2 months, and day 6 months. So that within a year, you finish the immunization. And it gives very good protection, 93 to 100% protection against acquiring CA cervix later on in life. So the government of India, I am sure you've read it all in the papers, recently, actually on the 26th or 28th of February, started the HPV vaccination program in India, where girls in the age group of 14 to 15 years, are going to be immunized with one single dose of HPV vaccine, given free of cost by all the government institutions, starting from the primary health center, right up to the medical colleges in the government. One single dose at age 14, free of cost. And hopefully they have found that even a single dose is very, very effective in children. Even though they advocate for 2 doses, a lot of studies have shown that even a single dose is very effective. Almost 160 countries out of 194 countries in the world have introduced 1 dose HPV vaccine as immunization for their children against CA cervix. So India is also going with that. And today, the Tamil Nadu government has started their program. Prime Minister Ji started the program in Jaipur, I think in Rajasthan. So that's going great guns. With regard to women and children living with HIV, organizations that are working with children living with HIV or women living with HIV have started in a small way providing this vaccine for their own patients. And I hope with time, the government of India will also take that over and, help us so that ART centers, the vaccination will become available for women living with HIV at the ART centers. In the private sector, it has already been started, both among women living with HIV, women without HIV, children living with HIV, and children without HIV. So that's the progress that has happened so far. It's a very good step. And I think it's very important that we move forward with this. Thank you.
Thank you, Dr. Glory. Dr. Kumarasamy, what are the gaps in progress towards 95, 95, 99 targets? And what are the proven ways to bridge the gap by end of 2026?
Right. Hi. Good afternoon, everyone. So I think coming to this target of 95, 95, 95, which every country, you all know that has been looking forward to reach. There are some countries are almost touched, but on the other hand, they are not able to sustain. So what this is you need to identify 95% of the people who's been living with HIV by doing the testing and link them to the treatment by putting on the currently available combination antiretroviral drug and make sure that they take the drugs and also make sure that they are virologically being suppressed. So this is what is called the 95, 95, 95. So this is a target set by the United Nations for the AIDS program across the globe so that people will start. It's not like a fixed rule. It's been set for a program so that people will maintain this target. And in future, they may go to 100% of that. But the obstacle being still significant number of people across the globe, is not being tested. Even in India, I don't have the right figures for today here, but the one what is released for the last year, which is around 80% of the people, nearly approximately around, some figure shows 78, around 80%, have been know their status, and remaining people, they do not know their HIV status. And if you see this, who really do not know the status is, we call it as what is called the key population or hard to reach population. This is mainly MSM population, young MSM, who don't come out for testing because of various stigma. And also, there are injecting drug users, who don't come out in our community, and you have to reach them. It's just been done by some NGOs, but not by them, where the HIV prevalence and as well as hepatitis C prevalence is extremely high in this population. And also being a stigma, which is one of the major barriers for finding these people, because people don't want to come voluntarily for testing because of stigma. That's one of the major barriers for identifying. Now, coming to the treatment, India is like one of those leading the way if you compare to all the other countries, because all the drugs are available, which are being recommended by the World Health Organization, and our national program, NACO, developed their own guidelines, adapting to the WHO guideline. All these medications are available in totally free of cost. There were a few, shortage of medications and disruptions happened on and off, but in a way that if you look into that as a whole, our national program were able to sustain this and able to give this over a period of years, despite all those interactions happens in many parts of the world because of these situations in the United States, where they cut the funding, particularly PEPFAR funding, CDC funding, and the funding to the global fund, and thereby many African countries and some of the Asian countries were disrupted, which India did not. India were able to do this. That's one of those really a great sign what our program has done. Coming to the viral load measurement. So again, if we talk as a whole, it's not widely uniformly available everywhere. There are countries that are scaling up. They've gone to a good level of getting this done. But in India, we do have viral load measurements. Privately, it's widely available. But in the government sector, it's been available, but not immediately the results have been accessible to the physicians who are prescribing the ARVs or to the patient population to do the appropriate counseling. Now, what we are hearing from different ART centers is there's a huge delay in getting these viral load reports back. It may take a month or even up to 2 months or even up to 3 months for them. By the time they're not able to contact the patients to make sure that if they are, have viremia, they have viral load, to make sure that they continue to take these medications. This is another one major obstacle. So this is things where we want what is called the point of care viral load diagnostics. You give the sample, you get the report the same day or not, which there are centers doing. We do have a machine, which is called Gene Expert, which has been scaled by many private centers, which is a wonderful thing where you can have the same day viral load. But on the other hand, it is not available in the program, which is another one of the major obstacles. As a whole, India is doing fairly well in terms of putting people on treatment and make sure that they adhere to the drugs. But on the other hand, still is not enough. We are not gone to this level of 95, 95, 95. But it's when I'm compared to many African countries. But in India, we have a huge number of hidden population, which has not been reached at all. So that's the reason we still need to identify another nearly 20% of the people. We are mainly injecting drug users, young MSM population, transgender community, even as well as in the general population who don't want to come out for testing for various stigmas. So stigma still continue to be a major barrier for getting into this 95, 95, 95, particularly for India. But if you see these other countries in Africa, of course, they also do have stigma. But on the other hand, for them, resources is a major problem because they have been hugely depending upon the bilateral funding, mainly from PEPFAR, CDC, Global Fund, which because of all these issues happening politically, and they are not able to get the appropriate funding from the bilateral donors. So they have been disrupted in many, many ways. In this aspect, India is doing well. But on the other hand, we need to do a little more better to identify the remaining people who do not know their HIV status. Over. Thank you.
Thank you very much. Dr. Tripti Gilada, you are an infectious diseases specialist. Can you please tell us something about the status of sexually transmitted infections? Or anything else you would like to share in the context of the conference?
Thank you so much. So it's a extremely relevant question at this moment in the HIV pandemic. With all the recent advances in HIV diagnosis, HIV monitoring, and HIV treatment, we are really looking at not just a good length or longevity of life, but also a very good quality of life. And in fact, now with better drugs, our focus is also moving just from treating with ART to actually thinking about non-communicable diseases. On the other hand, there continue to be patients who do present with advanced HIV disease. And like Dr. Kumar said, the first 95 is diagnosis. So when we talk about advanced HIV disease, it is almost always in individuals who are HIV infected but not on treatment. Now, why they might not be on treatment is because of two things. One, the HIV has gone undiagnosed until they really present with infections, what we call opportunistic infections. Or two, they have not taken treatment for various reasons, like stigma, like non-disclosure to the family, which makes it difficult to take medications. So these advanced HIV infections continues to be a challenge both in public and private sector. It has definitely gone down compared to the last decade, but it continues to be seen. The most important advanced HIV, the opportunistic infection that we see continues to be tuberculosis. So tuberculosis is the infection with the highest morbidity and mortality in HIV infected individuals. In fact, in certain regions where there is a higher prevalence of multi-drug resistant tuberculosis. Several studies have shown, our data has shown, that individuals with HIV are twice or three times more likely to get multi-drug resistant tuberculosis. And these individuals, when treated exactly in the same way, the same drugs that would go to someone who's HIV uninfected versus infected, will still have a higher mortality when it is with HIV and tuberculosis. So that's just to give you an example about how opportunistic infections can affect the course of the illness, even in this era when ART is available. The other important issue that continues to trouble not just those with HIV but otherwise is antimicrobial resistance. But of course, much more in those with HIV and lower immunity, because they will land up with infections more often. They will land up with in healthcare systems more often. And that predisposes them to receiving antibiotics. Sometimes a lot of these antibiotics are taken over the counter. Multi-drug resistant infections are acquired, and antimicrobial resistance continues to be a problem that needs to be addressed at a wider scale. Your other question was about other sexually transmitted infections, and we are seeing a changing epidemiology when it comes to sexually transmitted infection, especially in the current times of social media and dating apps. Casual sexual exposures have become much more common, in fact, very common amongst individuals or youngsters, ages 25 and below. Now, earlier in the time, people knew that they were being exposed to an infection because they were with commercial sex workers or escorts. And that is when they did see a risk. What happens in these casual relationships is they don't foresee a risk. They think they are with just another individual who's just like them. And that is where a lot of newer transmissions of sexually transmitted infections are happening. That's also the place where a lot of HIV transmission in the younger population is happening, is where the individuals or that entire generation is aware about HIV. It's not that they are ignorant, they are definitely aware about HIV, but they do not foresee that risk for themselves. So I think that responsibility of really creating that awareness, reminding them that casual sex is just as risky, both for HIV and other sexually transmitted infection, is something that we need to do as a medical profession, but also as a community at large.
Thank you. Thank you, Dr. Tripti. There are already questions there. Then participants, please type in your questions in the chat box. We already have a lot many questions. There is a question that is advanced HIV disease a big problem in India? I would leave it to the experts, those who want to answer. Dr. Gilada, would you like to say something?
Yes, it is a big problem. And actually, those who are practicing in HIV field for 20, 30 years, we have been always, nowadays there are new phrases come. We have been always practicing advanced HIV disease. We are always looking at the symptom, diseases before starting ART. Now, what has happened after the test and treat era, where the test and treat says that as soon as you see HIV, start shooting. That means you start ART. And with that, there are a lot of good things, yes, but there are also bad things where somebody who is sick with pneumonia or brain problem or tuberculosis, and you start ART immediately. ART will cause a problem in immunity. Immunity will increase, and there are the diseases which will become more because of heightened immunity, and they are called immune reconstitutional inflammatory syndrome (IRIS). That IRIS phenomena is sometimes more fatal than HIV per se or by HIV treatment per se. So I think we should be looking at advanced HIV disease from that angle, and there are some tests available which should be tested in government-run ART centers. Like cryptococcal antigen test is not available. So if there is a problem in brain which is to be diagnosed by a cryptococcal antigen test, it is not done. You started ART, that problem will become severe. Secondly, for advanced HIV disease, you must do baseline CD4 count. And in most pan-India ART centers, baseline CD4 counts are not done. So they do the HIV test, they start ART. After 6 months, they call and they do viral load testing, whether viral load is suppressed or not. In between, they stop, or they were doing very less often CD4 test, but now they started doing at least once in a year. The second problem is that the test is done, the reports are given in the next visit. So even if somebody is having a problem, you do not have any access to that person to come to you. Sometimes they may be given a proactive call, but the patient may not attend. So nowadays, when there are point of care tests available, where a patient kept waiting for 2 to 3 hours, reports are done, and then patient can be called, and you want to start test and treat same day, fine. And that's how our setup in Mumbai is a 3 hours turnaround time clinic. Everything, including CD4, viral load testing, X-ray, sonography, consultation, counseling is done within 3 hours. In most setup, they may not be able to do 3 hours, but 6 hours, 8 hours. Government setups work for 8 hours. So I think if you do that, secondly, if you take a proper history of a person, whether the person is sick, having fever, cough, headache, or kind of a weight loss, which is of a profound nature, more than 10% or more than 5 kg weight loss in few months, then you should have that suspicious eye and defer ART. Thankfully, at least in the beginning, they do kind of it was IPT earlier called isoniazid prevention therapy for tuberculosis, but now there is a INH and rifampicin combination which is given to prevent tuberculosis. So even if person doesn't have tuberculosis, TB can be prevented. And in similar cases where CD4 counts are done and they're below 200, the person can be put on the cotrimoxazole prophylaxis, which prevents not only PCP pneumonia, but at least 10 to 12 other infections, which are like opportunistic infections.
Okay, thank you. Dr. Kumarasamy, you mentioned the gene expert for viral load testing. Are there any made in India machines to do that, which might perhaps improve the frequency of viral load testing?
No,
We do not know.
all these, currently we do not have any indigenously developed point of care HIV viral load machines. Of course, we do have for TB diagnostics, but not for HIV. So these machines are available in India. In fact, the machines which are used by the TB program, which is called the Gene Expert, which is being repurposed even for HIV also. But only thing we need is a separate testing cartridge. But it is very expensive. And hence it has not been widely used, across India as compared to the conventional viral load, which is used by the RT-PCR. So, but if we can make it, cheaper, I'm sure, more individuals will use it, and as well as the programs will, can adapt it, and thereby you can have one thing called one-stop shop. You come in the morning, get your viral load, again, meet with the clinicians and as well as the, counselors, talk about the adherence, if they have low-level viremia, which can be done. So this is very, very important, the viral load, because what we are doing in HIV is we are treating the virus without knowing how much the viral load. We do not know whether these drugs are really working or not. The patients might say, we are 100% adhering to the medications. they're taking the drugs. But on the other hand, are they really taking this? Because it's a lifelong disease. It's a very important question. I think viral load availability, is very crucial for HIV care and as well as to achieve the 95-95 and for any purpose. And also, it's very importantly, today we have a science which shows that if someone who is virologically suppressed by taking these antiretroviral drugs, it is good for them. They will not develop any opportunistic infections, major comorbid conditions. But also, we have shown they will not transfer infection to their sexual partners, to their spouses or to the other sexual partner. This is what is called U is equal to U. Hence, viral load is very, very important, not only for treatment, but also for prevention. So if they are viremic, then we can even counsel them. Hey, you're viremic, you got a viral load, take the drugs properly. It will be good for you and as well as good for your partner. Hence, implementation of the point of care viral load, which is very, very important, particularly in a country like India. So Dr. Gilada was talking to you about these advanced disease and the importance of CD4. So this is something what's been now many programs are phasing out this CD4. I think that's a huge mistake because we need to know about the CD4 so that the appropriate baseline investigations which are required for diagnosing various advanced HIV disease will be implemented. Otherwise, someone who can have a higher CD4, the physicians might be doing unnecessarily certain assays which can be more costly either to the program or to an individual. I think by investing on the CD4, you'll be able to cut all those. And also CD4 measurements are very, very important to provide appropriate chemoprophylaxis for pneumocystis pneumonia as well as for toxoplasmosis. And also to schedule their patient's visit. If they have low CD4, we tell them come frequently and also, do appropriate care so that they won't acquire other infections, so on and so forth. Hence, these CD4 measurements, even point of care diagnostic, will be very valuable for the clinicians and programs, particularly taking care of the people, with HIV. Over. Thank you.
Thank you.
I just wanted to add, Shobhaji.
Yes.
Question: are there tests developed in India or they are manufactured in India? Yes, there are two companies. One is an Indian company called Malbio. They have developed HIV viral load test, but their test is not validated against the standard of care test.
Yep.
Whether it's a point of care or a kind of a conventional PCR. Their current standard shows that 1453 copies, and which is way above. We want 220 or 40 or 34, that kind of copies. Secondly, another company called Safid, they already started their manufacturing unit in Bangalore, and they are going to manufacture. I think they must have started manufacturing or it will come out. So when they come out, then the cost can go down. And
Sure.
Thirdly, another company called Sysmex, they also started their manufacturing plant in Gujarat, and they will come out with viral load testing. So once these 2-3 companies come, then there will be cutthroat competition. Anyway, HIV care is one of the cheapest care anywhere in the world if you compare the cost in India. So whether it's viral load testing or CD4 or anything, they are much more cheaper than managing a diabetes or other complicated hypertension.
Yeah. And also to this question on indigenous, there are few other academic centers also have developed this point of care diagnostics. But these are all not still validated, some validation going on. For example, Oxford University has developed one, which they have been doing with our group on some validation. But these are all in the very advanced stages. But to the question, are they available? No, nothing has been now validated and approved. But many of the things are in the pipeline. I think effort should be made how you can make it available very quickly. How, if they have funding issues, how you can fund them so that they have more validation and scientific studies can be done. If they have a bottleneck at the regulatory level, where how that can be smoothened up so that these kits will be quickly registered in India. So this is another major issue. Whenever new testing kits are available in many parts of the world, getting that in India is a major obstacle because it needs to be reviewed by the Indian regulator and should be registered. Still, for some of the TB diagnostics, like a test called urine lamb, which is a very cheaper and very inexpensive, easy test to diagnose TB, especially people who got extrapulmonary TB, widely available across Africa since last more than 2 years, but not still registered in India. I think these are some of those issues. If we can take care of our regulatory mechanism, some of these point of care diagnosis can be much more easily available in India. Thank you. Over.
Very true, Dr.
Just to add one point, this lamb test is approved recently in India. So I think it will be made available probably within a month or so commercially. Otherwise, it is available in program, but for research purpose also, but not for kind of
diagnosis.
Okay. We have many questions for Dr. Gloria Alexander. One question is, what role do community health workers play in reducing mother-to-child transmission rates? And also, I would like to add what could be the role of community health workers otherwise in controlling HIV?
Right.
Yes.
First of all, before we go there, I just need to also talk about what the government of India is doing, because I'm not sure if people are aware of what the government of India has done, the National AIDS Control Organization. From the year 2004, the National AIDS Control Organization has opened 794 ART centers all over the country, where antiretroviral therapy is given free of cost to every person who has HIV. And this has been going on for the last 22 years. So that is one of the most inspiring programs the world over, our National AIDS Control Organization's free ART program for people living with HIV. And they have been able to sustain it for 22 years, and it is still going on. So that is a very big point that we need to take note of. And I would also like to say that in addition to that, there are a whole lot of NGOs, private medical colleges and private sector, which is complementing the work of the government. But the government is the main player in this field. Now, coming to, in that same context, I want to mention another thing. The government NACO also has around 700 Suraksha Seva Kendras, where they provide preventive services for people at risk of acquiring HIV. So people can go there, get themselves tested for HIV, can make use of all the services that they have available to protect themselves from HIV. In this context, I'd just like to mention one thing. The biggest thing that we can give for people to prevent themselves from getting HIV, this is for people who are at high risk of acquiring the infection but don't have the infection yet, is PrEP, what we refer to as pre-exposure prophylaxis. And this is given in the private sector, just to take off in the government sector. But this is a drug that we give people who are at risk of acquiring HIV so that they can prevent themselves from getting it. It can be taken as what we call on-demand PrEP, where they take about 5 doses within 48 hours, or it can be taken for a week when the people are expecting to have some kind of sexual exposure, or it can be taken on a regular basis if they have a regular partner where both partners are at risk of acquiring HIV. So this is the most effective way to prevent HIV from one person to the other through the sexual route. What was your second question, Shobha?
Another question is that what are the best practices for infant feeding in the context of HIV?
So in the context of HIV and in the context of India, breastfeeding is the best thing that a pregnant mother can give to her newborn child, because India has been for so many years talking very pro breastfeeding, and it's the best thing that a mother can give to her child. Now, if a woman is living with HIV, she is pregnant and her viral load is undetectable, the risk of her transmitting that infection through breast milk is negligible. The same concept of U is equal to U, what Dr. Kumar was talking about. If a mother has an undetectable viral load, then the risk of her transmitting that infection to her child, either during pregnancy, during labor, delivery, or during breastfeeding, is negligible. In my own personal experience, for the last 10 years, we have delivered more than 500, 600 children to HIV positive pregnant mothers. Not one of them is positive. Okay. And about 90% of them have all opted for breastfeeding. So they have all been breastfed by their mothers. All the mothers had undetectable viral loads. So breastfeeding is the best choice that we can give in the current context in India. In the developed world, they all opt for exclusive formula feeding. But in our country, exclusive formula feeding has various problems, yes, such as aspiration, pneumonia, diarrhea, because we cannot maintain that level of, yes, hygiene which is required for exclusive formula feeding. So breastfeeding is the best way to go, but it's an informed choice. We explain all this to the mother and she makes her choice on whether she wants to go for breastfeeding or formula feeding, and 90% of our mothers have opted for breastfeeding.
Okay. And this is happening in the government program also?
Also, yes.
Yes. Okay, thank you. Now, another question is, how effective is screening for HPV in the infant of an HIV positive mother who
So-
also has HPV?
No. We ideally, it's not a guideline. It's not being done
Yes.
that a newborn baby born
Yes.
from a mother living with HIV is tested for HPV. It's not done. It's not a guideline.
Mhm.
The good thing is that by the time that child reaches the age of 9 years or 10
Yes.
years, she is eligible for the HPV vaccine
Right.
and she will get it, which will protect her from getting it later on in adulthood. But this is not a guideline now, so we don't routinely test newborn babies for HPV, whether they are HIV positive or HIV negative. HPV routine testing is not done, though vertical transmission of HPV can happen. But the child eliminates the infection spontaneously.
All right. All right. Another question is HPV vaccine going to be prioritized for girls with HIV? And also, is it going to be prioritized for boys or other genders? And which vaccine is being rolled out in the government program?
So, if you look at all the literature for all these vaccines, it very specifically says that this vaccine can be given for both girls and boys in the age group of 9 to 26 years. That is Gardasil 4 and Cervavac. All of these vaccines can be given to both boys and girls in the age group of 9 to 26 years. The things that you have to remember is that CA cervix is the second most commonest cancer in our country in women today. And therefore, the prioritization is for girls. But like for us at Asha Foundation, we are giving the vaccine to both girls and boys in the age group of 9 to 26 years. When they come to us, we give it to both of them.
Okay.
Now, in girls, the vaccine can prevent not only CA of the cervix, it can also prevent CA of the vagina and CA of the vulva. In boys, it can prevent oral cancer, oral pharyngeal cancer, cancer of the anal canal, cancer of the sexual organs. So, especially young boys, it can be given 9 to 26 years. So, we have been giving it if they come forward for it. But right now, the government is prioritizing girls. Maybe later on, it will expand. This is only the first step. Later on, it may expand to include all the young population. The vaccine that we're using, which the government is giving, is Gardasil 4. The Global Vaccine Initiative has given millions of doses free of cost to India, and it is this vaccine that is being used currently in this program that is being rolled out.
Okay. Thank you
Shakti,
very
I wanted
Yes.
to add one more thing.
Yes, please.
All the good things we have to change for the better. Good
Yes.
that every day is rolling out.
Mhm.
But basically, how does girl get HPV? Gets from
From the
boys.
boy.
Boys. So if we have a policy paralysis at that end, that we are going to prioritize only girls and boys are not getting. Boys are at higher risk than girls of getting themselves and passing on. Secondly, many of the girls are 98%, 97%, they are heterosexual. And they cannot transmit girl to girl HPV. But boys can transmit boys to boys and boys to girls. So I think that is one thing. And secondly, because of this only, the Indian-made vaccine is called Cervavac. Now, when I'm prescribing Indian-made vaccine, which is half the cost of the international vaccine, the boy says, no, this is Cervavac, I don't have cervix. So name also is a misnomer.
Okay.
And we should look at those issues and prioritize both girls and boys. Secondly, the current circular which says about the girl, those girls which are turning 14 and below 15 will be given vaccine. Again, there is a policy paralysis here. What about the girl which is between 15 and 16, not started sexual activity? So all those girls which have not started sexual activity, it works with even Gardasil 4 has even a single dose below 15, about 15, 2 doses, as against 2 and 3 doses. But if you are not providing vaccine to a girl who is 15 plus one day also, that will be again a wrong thing to do, because NFHS survey shows that below 15, the sexual activity is 10% in India, NFHS 5, and that was 2019 to 21 survey. When NFHS 6 comes, which is 25 to 26, data comes, that will open the Pandora's box. The sexual activity starts quite early. And a lot of sexual activities also because of early marriages. So that will open up that issue, and we need to look at from all this angle. It's good that we start vaccinating first 14 to 15, but anybody who turns up for 15, 16, 17 should be given.
Yes, right. All
So
right. Yes, please.
The other thing is that MSMs, men who have sex with men, are prone to getting all these cancers that I talked about, including warts. We forgot to mention warts. The strains 6 and 11 are also present in this vaccine, which prevents against genital warts, and that's also, which can later on become cancerous. So that is why we open it out to boys also, so that if there are any MSMs there, they can also protect themselves from acquiring cancers later on in life.
All right. Thank you. Now we will close the press conference with short messages from each of our speakers. Message for ASICON 2026. We will begin with Dr. Gilada and then a short one-line message.
See, with the 17th ASICON, which is also going to the 18th now, next year, and which has been in existence since 2000, ASI. We'd like to see that it is not only quantity of life which is important, we add quality to quantity of life. And therefore, we are expanding our entire scientific program to encompass a lot of other issues. And therefore, my request to those people who are directly or remotely concerned about HIV and infectious diseases should come and join the conference.
Thank you. Dr. Gloria Alexander, your message.
I would like to align my message with that of the IAS. The theme for this year's 2026 AIDS conference being held in Brazil is Rethink, Rebuild, and Rise. And that is where, there have been so many political tensions, so many political decisions, war, disaster, all of this is happening, pandemics, all of which have impacted the care for people living with HIV, so much so that we've had to rethink, rebuild, and rise. So I just want us to keep that in our minds as we move forward with the AIDS, with our ASICON 2026. It's a beautiful agenda, covers almost all topics, and I hope that the participants and the delegates will enjoy what we have on hand to offer.
Thank you. Thank you. Dr. Kumarasamy.
Yeah. So I think, there are conferences and webinars, everywhere. People tend to attend and each one will have a different theme. So, but if you look into this scientific agenda of these ASICON 2026, which has been developed in a way that these are all very key priorities in a clinical field, particularly in a setting like India and lower middle income countries, what the clinicians face. So not just on abstract related topics, these are all very key clinical pertinent questions. Whenever we are treating patients with HIV, when you put them on antiretroviral therapy, when they develop certain adverse effects or complications or some other comorbid condition, how do you manage them? So the scientific agenda is developed in a way that how to critically answer all this. And the faculty who are going to address, who are all eminent figures, who have been involved in providing patient care for more than a decade, and are also involved in doing some clinical research and publish in that particular field. So hence, our conference is very unique as compared to several webinars and several international meetings where people attend. Hence, it is very, very important for the Indian clinicians when they're taking care of patients to understand what are those patients come across and how to manage them and interact with the faculty. So with this, we look forward to invite all of you and as well as kindly spread the message to key clinicians who are involved in HIV care, infectious disease care, even in other fields of medicine who would like to learn more about this, should attend this conference.
Okay, thank you. Dr. Trupti Gilada.
So the theme of our conference is adding life to years with science and solidarity, and I think it pretty much really encompasses what we've really thought about achieving at this conference is really talking about scientific updates, but also coming together and collaborating and finding solutions for our problems, and that we can only do when we work with science and with solidarity. So welcome all of you to ASICON 2026, and we really hope that we are able to work with some good science out there.
Thank you very much. Thank you for this very informative session. And let us pray and hope for peace in the world as we see what disruption is being caused right now, all in so many regions, geographical regions. And see you and wish all of you a very fruitful ASICON 2026. Namaste.
Thank you.
Thank you.